Assalamu alaikum everybody and good morning. I welcome you all to this third day of PSSLD meeting, 14th annual conference, and today we are having some exciting talks and we will be starting with one of the new initiative of PSSLD for this young fellows and resident, which is called as the Rising Star. I am Dr. Miyasha Yusuf, working as Assistant Professor of Gastroenterology at Peshawar Medical College. So I will start to proceed my session. Today I am moderating this new session of Rising Star. For this session, we are having chair with us. So chair are Professor Masood Sadiq, who is head of the Department of Medicine, Foundation University Medical College, Islamabad. Professor Altaf Bakir, who is Professor of Medicine. Dr. Ali Haider, Associate Professor of Medicine at Shaheed Muhtarama Benazir Bhutto University. Altaf Sheikh, who is working as Professor of Medicine at Lahore, and Sadiq Achakzai, who is working as Consultant Gastroenterologist and Hepatologist at Bolan Medical College, Quetta. Today we are having three presentations for this Rising Star Award. So the presenter will be present over here and they will be available to answer your queries, and this will be a session, a constructive session, so we will like to take input for construction of these Rising Star to make a good article and good paper from this presentation. So I will like to invite my first presenter, who is Dr. Muhammad Asim, and who is presenting the enigma of autoimmune hepatitis overlap syndrome. Dr. Muhammad Asim.
Assalamu alaikum. I'm Dr. Muhammad Asim, Senior Registrar, Department of Hepatology and Gastroenterology, Ziauddin Hospital. The topic of my presentation is the enigma of autoimmune hepatitis overlap syndrome. Before we delve in, there are certain questions that remain unanswered so far. Number one, do patients simultaneously have two diseases? Are they the product of inaccurate diagnostic criteria that result in the diagnosis of two conditions when patients actually have one? Is there in fact a continuum between the two disorders? Autoimmune overlap syndrome is usually a reflection of an inherent distribution of clinical features across different patient populations. The more extreme the distribution, the more distinct the apparent overlap. The suspicion arises when there is deviation in the normal clinical course or expected response to therapy. It is also a reflection of inadequacy of present diagnostic tests. Theoretically speaking, autoimmune hepatitis can overlap with most of the primary hepatic pathologies, but most often the overlap is seen between AIH and PBC and autoimmune hepatitis and primary sclerosing cholangitis. It is rare to see the overlap between PBC and PSC. So far, only a couple of cases have been reported in the literature. Interface activity is one of the telltale facets of autoimmune hepatitis, but it's the degree that matters the most. Mild degree of interface hepatitis, as illustrated in this graph, can be seen in PSC as well as PBC patients. There are certain caveats in the diagnosis of autoimmune hepatitis overlap syndrome. One of them is radiological. When MRCP findings are falsely suggestive of PSC, that may actually be due to hepatic fibrosis distorting biliary anatomy. We all know that PSC is only seen in about 1.7% of AIH. The result is overdiagnosis of PSC. Also, we should know that MRCP can be abnormal with non-specific changes in 10% of autoimmune hepatitis. Another caveat is positive antimitochondrial antibodies that can persist, appear, disappear over time. They can be seen in 6 to 18% of cases of autoimmune hepatitis, but response to steroid is usually well. Another caveat is lymphocytic non-destructive cholangitis, insufficient for overlap diagnosis, and misuse of diagnostic scoring system like International Autoimmune Hepatitis Score is another issue. Because it's usually non-discriminative in nature, it lacks prospective validation for autoimmune hepatitis. It is not designed for picking up overlap syndrome. Overlap technically can be immunoserological, like positive ANA antibody as well as AMA antibody. It can be biochemical, radiological, or histological. There can be varying combinations of all of the above. Moving to autoimmune hepatitis and primary sclerosing cholangitis, This overlap is usually seen in younger age, male-dominant population. Prevalence ranges from 1.7 to 12.5%. If a patient with autoimmune hepatitis develop IBD, then further evaluation for PSC is likely warranted. 30% of cases in one of this study with autoimmune hepatitis and IBD had features of PSC which were previously unrecognized. This diagram is illustrating relationship of various variables to autoimmune hepatitis and primary sclerosing cholangitis with overlap in between. AIH is more common in female population, IBD is more often associated with PSC, and response to immunosuppression is satisfactory usually in cases of autoimmune hepatitis, while the prognosis is relatively worse in case of PSC. To score or not to score is another issue. The International Autoimmune Hepatitis Scoring System has excellent specificity for PSC, but key diagnostic tools are MRCP and liver histology, and caution should be used with regards to biliary changes that can be seen in AIH non-specifically. This slide is illustrating a case of a young patient who at the age of 14 years had typical interface hepatitis, suggestive of autoimmune hepatitis. At the age of 19 years, when she developed radiological features of cholangiopathy, obvious bile duct lesions along with interface activity were seen. And at the age of 21 years, typical PSC-like changes were evident. This is an example of how autoimmune hepatitis in young age can transform to another classical disorder over time. Moving to treatment, empirically, immunosuppression and ursodeoxycholic acid are both used, and liver transplant is reserved for end-stage liver disease. In one study, the immunosuppression along with ursodeoxycholic acid was able to suppress aminotransferase levels for a period of about 5 years, but no change in prognosis was documented. Ursodeoxycholic acid monotherapy has no efficacious role. It has got relatively poor prognosis, and over a mean period of 12 years in one of the study, cirrhotic population increased from 19% to 56% at the end of observation. Post-transplant, there are higher recurrence rates and comparable graft and patient survival. What advantage diagnosing a cholangiopathy may allow for? It may allow for therapeutic biliary intervention, heightened awareness of poorer prognosis, lower threshold for investigating IBD, and cholangiocarcinoma surveillance. Next is primary biliary cholangitis and autoimmune hepatitis overlap syndrome. We all know that PBC is an immune-mediated cholangitis, but one should not mistake a non-response to urso as overlap, forget to look specifically for ANA markers like SP100, and assume that interface activity has the same significance as it does in AIH. Paris criteria is often used for diagnosing PBC and AIH overlap. It has got two components, one for PBC and one for autoimmune hepatitis. If you look at the components of PBC, alkaline phosphatase twice the upper limit of normal, or gamma GT 5 times upper limit of normal, presence of AMA and liver biopsy showing bile duct lesions are included. For autoimmune hepatitis, ALT levels 5 times the upper limit of normal, IgG levels twice the upper limit of normal or positive ASMA, and liver biopsy showing moderate or severe periportal or periseptal lymphocytic piecemeal necrosis are included. It has got a sensitivity and specificity of 92% and 97%, but the problem is it requires further validation and it cannot capture the less severe forms of overlap syndrome. In the natural history of PBC, in one study, 100% of untreated patients developed interface hepatitis in 4 years, and a significant number of patients had positive ANA or ASMA antibodies. Can we use international autoimmune hepatitis score for this sort of overlap? It has got just 50% sensitivity in diagnosing overlap syndrome related to PBC and AIH. Moreover, it suggests that patients with autoimmune liver disease should be categorized according to the predominant feature, and that the patient with overlap feature should not be considered as distinct diagnostic entities. There are certain reports and cases that have shown that anti-double-stranded DNA is thought to be a potential marker of PBC-AIH overlap. Moreover, anti-GP210 is also frequently seen in overlap syndromes with interface activity. But again, this requires further research. Moving on to treatment, those patients who have not satisfied the Paris criteria improved with conventional immunosuppressive therapy, while those patients with predominant PBC and background features of AIH have improved with ursodeoxycholic acid alone. Those who satisfy the Paris criteria for overlap syndrome show response to combined treatment with steroids and ursodeoxycholic acid. This is an excerpt from a recent trial that was related to the role of budesonide in those cases of PBC who showed non-response or partial response to ursodeoxycholic acid. Patients were randomized to either budesonide group or placebo group, and at the end of 36 months, results were evaluated. The results showed that biochemical parameters did improve, but liver histology did not show any significant improvement. IgG4 associated hepatitis is another overlap syndrome on the horizon. We don't know if it's a subtype of autoimmune hepatitis or as a part of more general systemic disease. It is characterized by significant accumulation of IgG4 expressing plasma cells in those patients who met the diagnostic criteria for AIH. Another typical feature is hepatic inflammatory pseudotumor formation, especially the lymphoplasmacytic type. According to Nakanuma's criteria, it is characterized by elevated concentration of serum IgG4 and infiltration of IgG4 plasma cells 10 or more. It's responsive to steroid therapy, and ALT normalization after the steroid treatment was shorter for IgG4 group of autoimmune hepatitis. So we can say that accumulation of IgG4 plasma cell might be a surrogate marker for the prediction of steroid treatment. If we move on to conclusion, we can say that overlap classification at presentation is not recommended because there is no opportunity to see the response to primary therapy with also for PBC and steroids for AIH. In the setting of a new diagnosis, the predominant process is treated first and time given for a full treatment response before additional therapy. Similarly, a young patient with colitis who has a hepatic presentation would be treated initially for autoimmune hepatitis, even if there is a concern that true autoimmune liver disease was an evolving PSC syndrome. In the setting of established autoimmune liver disease, wherein a stepwise, otherwise unexplained change in presentation occurs, then therapy is augmented with either urso or corticosteroids. The bottom line is clinical judgment is the gold standard. Thank you.
Thank you, Dr. Asim, for such a nice presentation. I will like to take input from Dr. Ali Haider. Sir, if you can hear us and if you want to have some input or comments. Okay. So, I would like to request Dr. Farhana Kayani, the second rising star, to present her session, and we will take comments or question at the end of all the three sessions. Dr. Farhana Kayani is going to present a topic with the title of Development of a Nomogram to Predict the Severity of Hepatic Fibrosis.
Assalamualaikum. I'm Dr. Farhana Kayani, consultant gastroenterologist at Ghulam Fareed. And the title of my study is Development of a Nomogram to Predict the Severity of Hepatic Fibrosis by Non-Invasive Markers and Treatment Allocation with Outcomes in Non-Alcoholic Fatty Liver Disease patients. So as we all know that obesity and associated comorbidities, they are reaching pandemic proportions worldwide, and non-alcoholic fatty liver disease is the hepatic component of this syndrome. It has been recognized as one of the most common causes of hepatocellular carcinoma, and it contributes to a large societal and health problem. As we all know that the diet and lifestyle modification, it remains the mainstay of the treatment, but there are other interventions like pharmacological, endoscopic, and surgery that can be used in this regard. However, the indication of like when to use and what to treat, with what to treat, it is a question that remains unanswered. So coming to an important question, like why is it important to diagnose NASH and hepatic fibrosis? Our first aim is to identify NASH, as it is important because it increases the risk of progression to liver fibrosis, and therefore it helps in identifying treatment candidates. Our second aim is identification of fibrosis because it increases the risk of mortality that has already been proven by prior multiple studies. Therefore, it helps in taking active decisions regarding treatment to avoid further damage to the liver and help in preserving the remaining functions. So coming to the aim of our study, the aim of the study is to evaluate the hepatic fibrosis stage in non-alcoholic fatty liver disease by all non-invasive markers, and moreover to evaluate the outcomes of patients who are undergoing treatment that is allocated respectively, focusing on the improvement of hepatic fibrosis stage. So in our study, the patients will be pooled prospectively on a questionnaire. All demographic data like age, sex, comorbidities like hypertension, diabetes, ischemic heart disease, hyperthyroid, prior history of alcohol, clinical examination like BMI, waist circumference, blood pressure readings, lab parameters that start right from right and complete blood picture, liver synthetic functions, thyroid profile, for the diabetes, RBS, HbA1c, serum albumin, fasting lipid profile, and virus serology. However, we have to use ultrasonography and transient elastography for scanning purpose. As we already discussed, like regarding history, the comorbidities that are important to us, who are proven by prior studies to have strong association with non-alcoholic fatty liver disease are diabetes mellitus, hypertension, ischemic heart disease, hypothyroid, and polycystic ovarian disease in females. So considering these comorbidities, each one corresponding point is given. Moving on to further history, we have to take history of alcohol intake. It should be less than 3 ounces 2 times per week, as alcohol is identified a common cause of steatosis. However, if alcohol intake is above this level, so such patients will be excluded. Similarly, we have to take we have to enroll the patients who had prior history of treatment for NAFLD with no response, and we will give them 1 mark too. Moving on to the clinical examination, so as we discussed, that it includes the BMI, waist circumference, and blood pressure reading parameters. So taking into consideration our population, our cutoff levels will be in correspondence to Asians. So any level more than 23 to 26.9, 1 mark point would be given. If it's more than 27, 2 points would be given. Similarly, the cutoff level for waist circumference for Asian women would be 80 centimeter, and for Asian men it would be more than 85. And the blood pressure reading cutoff level would be lesser than 140 by 90 millimeter of mercury and more than 140 by 90 millimeter mercury. So as we discussed, what are the fibrosis scores that are used, the non-invasive test to predict the fibrosis of liver. One of the commonest one is AST to platelet ratio index score, as we all know it as APRI score, and it takes into account the AST and the platelet count. In the meta-analysis, it was concluded that an APRI score greater than 0.7, it had a sensitivity of 77% and a specificity of 72 for predicting significant hepatic fibrosis. Similarly, the fibrosis score, it is a fibrosis score, a 4 score, and it is also used to predict the hepatic fibrosis. It takes into account the following parameters that include age, AST, platelet levels, and however, the cutoff level in fibrosis score is 1.45. If it is less than 1.45, it had a negative predictive value of 90% for advanced fibrosis. Similarly, if the fibrosis score is more than 3.25, then it has got a positive predictive value of 65 for advanced fibrosis. However, the APRI score, it cannot be used alone. It won't be not enough to identify the patients with advanced fibrosis. However, it is always used in conjunction with fibrosis full score or with the transient elastography. One of the other common scores that are used is NAFLD score, and it takes into account the age, BMI, hyperglycemia, platelet count, albumin, EST, and ALT levels. It is calculated by a long formula, and when the result is like less than minus 1.45, there is 90% sensitivity and 60% specificity to exclude advanced fibrosis. But if the value is more than 0.67, there is evidence of presence of advanced fibrosis. So as we already discussed, the non-invasive tests that are APRI, FIB4, NAFLD score, we have to take into account the viral serology, thyroid, and the diabetes profile, along with the cholesterol levels too. So moving on to the imaging. In imaging, we need to take into consideration the ultrasonographic findings and the fibroscan, that is to identify the fibrosis stage along with the statosis. So the corresponding points are given to each increasing fibrosis stage and statosis stage grading respectively. So we already discussed, these are all those parameters that would be taken into Nomogram, the parameters that are in history, the clinical examination, and the lab parameters and ultrasonography. So the total points in female would be 31, and in males it would be 30. So this nomogram map, it predicts the predicted probability of the severity of hepatic fibrosis in NAFLD patients. And in this, for each covariate, value is recorded, and those points are actually noted down. And for each covariate, it is repeated again, and a total score is taken that corresponds to the severity of hepatic fibrosis. So as we discussed, like based on all prior studies that are using non-invasive markers, the clinical examination, the transient elastography to predict the fibrosis stage. So depending upon those, we can easily conclude that treatment can be safely allocated to such patients based on these scoring. So according to my study, if the total scores comes out to be 7 out of 30 in males and 31 in females, dietary consultation along with lifestyle and modification can be advised safely. But if the scores they come out to be more than 7, less than 24, medical treatment for NAFLD, obesity, diabetes, hypertension. But with the score of more than 25, depending upon the patient's health and condition, along with the comorbidities, we have to think of surgical intervention versus endoscopy. So as we discussed, the points less than 7, it would be lifestyle modification, but the similar points more than 7, but less than 25, medical treatment like metformin, pioglitazone, simvastatin, vitamin. And if the points are more than 24, surgical intervention versus endoscopic intervention can be used. These patients need to be followed for a period of 6 months further with BMI, APRI, FIB4, and a transient elastography to focus on improvement of hepatic fibrosis. So just to conclude, based on my study, the main aim is that NAFLD can be diagnosed with complete and detailed history, clinical examination, non-invasive tests, if they are done in an appropriate clinical setting. The important question of fibrosis staging for prognosis can be answered by non-invasive tests and imaging. A sequential approach to diagnose by using all these markers, we can accurately diagnose fibrosis in more than 80% of the patients. However, why is it important to identify patients? It is because it will help us in identifying the treatment candidates, and especially like who will need the drug treatment versus surgical or endoscopic intervention. It is important to understand for better prognosis and to decrease the disease burden. Thank you.
Thank you, Dr. Farhana. Our next presenter is Dr. Ghulam Fareed, who is going to present a topic titled Acute on Chronic Liver Failure, a life-threatening medical problem with geographical differences and global controversies.
Assalamu alaikum. My name is Dr. Ghulam Fareed. I am gastroenterology instructor at Khan University Hospital. Today, I will be talking about acute on chronic liver failure. This is a life-threatening medical problem with significant geographical differences and global controversies. This is my presentation layout. I will be talking about definition and history, global efforts for ACLF, then geographical differences, and at the end, I will be discussing some global controversies regarding acute on chronic liver failure. There is no consistent definition of ACLF in the literature so far. Although different international societies have proposed their definitions, but still we don't have a single universally accepted definition for acute and chronic liver failure. If we go back in history, the term acute on chronic liver failure was first introduced by Ornishi et al. In 1995 in order to define two insults affecting liver simultaneously, that one being acute and the other being underlying chronic condition. Then followed by Jalan and Williams used this term in 2002. Talking about the global efforts of ACLF, so almost every continent has contributed its part towards the research on acute and chronic liver failure. So there are four well-known international societies, two from West and two from East, have done extensive work on acute and chronic liver failure. European Society for the Study of Liver Diseases and North American Consortium Study for End-Stage Liver Diseases has done their prospective observational studies in Europe and North America in order to define ACLF, assess patients of ACLF and their outcomes. A Basel and Chinese group on the study of severe hepatitis B are the leading societies from East working on ACLF on the other hand. Now moving towards the geographical differences. As we all know, when there is a global effort, there will be some differences considering different continents or different areas around the globe. So first we will talk about definitions. So these are the definitions which are proposed by different international societies. First, talking about Aclf. So they said that it is an acute deterioration of pre-existing chronic liver disease, usually related to a precipitating event and associated with increased mortality at 3 months due to multiple organ failure. On the other hand, Nexerd said that this is a syndrome characterized by acute deterioration in a patient of cirrhosis due to infections presenting with two or more extrahepatic organ failures, whereas on the other hand, Ipazal is supporting a concept that acute hepatic insult manifesting as jaundice that is more than 5 total bilirubin and coagulation that is more than 1.5 INR complicated within 4 weeks by ascites or encephalopathy in a patient with previously known or unknown chronic liver disease. Similarly, Chinese group have their own definitions. So obviously it is not that easy to remind or it's not that easy to remember all these definitions all together. So moving towards the severity assessment scores, so EASL has included these 6 organ systems in order to assess patients' severity in patients with acute and chronic liver failure. And these organ systems include liver, kidney, brain, coagulation, circulation, and respiration. And the values that are marked as red, these are actually organ failure as per definition of EASL. So if we apply these organ failure landmarks or cutoffs on grading of ACLF that was proposed by EASL, so they said no ACLF when there is no organ failure. They said this is ACLF 1A when there is single renal failure and ACLF 1B when single non-kidney organ failure. When there are 2 organ failure, this is ACLF 2, and when there are 3 or more organ failures, then this is ACLF grade 3. Now moving towards North American Consortium for Study of End-Stage Liver Disease, they have included these 4 organ systems, that is brain, kidney, circulation, and respiration. And failure of organ system are marked as red. That is, just for example, if we talk about brain, then West Haven grade 3 or 4 encephalopathy will be considered organ failure in this case. So, definition of ACLF as per NAFLD is a syndrome characterized by acute deterioration in a patient with two or more extra hepatic organ failure. So, below are the four organs which they assessed while assessing severity of patients in acute and chronic liver failure. An important point to note here is absence or exclusion of liver and coagulation by NAFLD while discussing severity of ACLF. Moving towards APASL, so APASL has created a scoring system known as APASL ACLF Research Consortium scoring system, the total points from 5 to 15. So there were 5 variables including liver, kidney, brain, coagulation, and lactate levels. And each variable has been given scores from 1 to 3. The values which are marked as red are actually those which are labeled as organ failure by APASL. So APASL categorize acute or chronic liver failure into three depending upon this scoring system. So ACLF type 1 is score 5 to 7, ACLF type 2 is score 8 to 10, and ACLF 3 is score from 11 to 15. Similarly, if we see a Chinese group on study of severe hepatitis B, they have used Aclf C organ failure scale as by EASL, and it is almost similar by the scoring system used by EASL. But there are two major differences in between Chinese group and EASL. One difference is the underlying etiology of chronic liver disease. In European population, majority of them had alcoholic liver disease or hepatitis C as an underlying etiology. On the other hand, Chinese group has predominantly hepatitis B as an underlying etiology. That was one difference. And another difference is subgrouping of type 1 ACLF. So Chinese group has defined 4 subgroups under the heading of, so including single renal failure, single liver failure, single organ failure other than above two, and single cerebral failure. So important thing over here is single renal failure, that even Chinese group has considered kidney failure on top of all other organ systems, including liver to begin with. So moving towards global controversies, the first controversy is underlying liver condition, and or one can say what is chronic. So EASL and NAFLD has included those patients which were cirrhotic with or without prior history of decompensation. On the other hand, APASL has only included those patients who were cirrhotic, but there was no prior history of decompensation. That is index presentation. So they only included those patients who had index presentation, and they excluded all those who had prior history of decompensation. And there is a very good table in APASL 2019, which is actually highlighting the differences in between acute decompensation of cirrhosis and acute and chronic liver failure. Another entity is chronic liver disease without cirrhosis. APASL and Chinese group has included even those patients who had chronic liver disease without cirrhosis, and this group was actually excluded by EASL and NAFLD. So now if we look at this figure and see well-known entities just like chronic liver disease and cirrhosis, so we already know that there may be two outcomes. One is either when the disease will progress, the patient will either need liver transplant, or the ultimate other outcome will be death. Similarly, in acute liver failure, there will be either full recovery or liver transplant or death. But if we focus on ACLF, it will be either liver transplant or death. But if in case patient will recover without liver transplant, then what? This is the question. Because in later on, if this patient has another acute insult after full recovery, then what will we label that insult as a second episode of ACLF? And if we go on, then the third episode and the fourth episode of ACLF. So this is the area which is under debate, and this is a major global controversy. So another is defining ACLF with concomitant extrahepatic organ failure. As per EASL, extrahepatic organ failure like renal failure is mandatory for defining ACLF. Similarly, NAFLD has even excluded liver dysfunction and coagulation abnormalities while assessing their patients for severity of ACLF, supporting a point that ACLF can even occur without hepatic dysfunction, which is actually totally against the concept supported by Apasal. Apasal is saying that it is actually a primary hepatic insult which will lead to acute and chronic liver failure with sequential involvement of other organ systems. So, if we move on, the third global controversy is time duration to define ACLF. 4 weeks as per Apasal, 12 weeks as per EASL, and there is no specific time duration by North American Consortium for the study of end-stage liver diseases. Moving forward, there is another controversy is acute insult leading to acute on chronic liver failure. That what do you mean by acute insult? So EASL is supportive of both hepatic and extrahepatic acute insults, especially infections. On the other hand, NAFLD supports extrahepatic insults, just like infection, as a predominant cause of ACLF in their study population. Chinese are supporter of both intrahepatic and extrahepatic insults, whereas Apasal, on the other hand, is saying that it is predominantly a hepatic insult leading to ACLF to begin with, followed by other system involvement. Now, if we see this figure and try to find out what do we mean by acute insult, so we simply divide acute insult into either it is hepatotropic or non-hepatotropic. Hepatotropic insults can be further divided into non-infectious or infectious. Similarly, non-hepatotropic insults can be further divided into infections and non-infections. And there are some examples written in front of each category. So another well-known controversy is whether sepsis is cause or a consequence of ACLF. So now if we look at this figure, so we already know that in ACLF there is significant systemic inflammatory response syndrome. And when there is a significant systemic inflammatory response syndrome and there is concomitant infection, then this is sepsis by definition. And EASL and NAFLD are supporter of this point that sepsis can lead to ACLF, which we can see on this slide as well. But on the other hand, Apasal is supporter that sepsis is not the cause rather than a consequence of ACLF. So now if we see this figure and I highlighted the non-infectious etiology or the acute insults leading to ACLF. So this is the point which is supported by Apasal on the other hand. But this is the area of controversy as well. When there is extra hepatic acute insult in a patient of chronic liver disease and that patient develop acute on chronic liver failure, then what? Whether we will label this as sepsis induced or sepsis in ACLF. Just an example, if a patient of chronic liver disease has severe cellulitis or urinary tract infection that is leading towards ACLF, then we are not sure whether we will be label those patients as sepsis in ACLF or sepsis induced ACLF. So moving towards sixth controversy, this is reversibility of ACLF syndrome. So Apasal has taken all patients with chronic liver disease. So their study population has cirrhotic as well as non-cirrhotic patients, supporting reversibility of ACLF to some extent. On the other hand, EASL and NAFLD has included all cirrhotic patients, even those who had a prior history of decompensation. So they did not describe anything related to reversibility of ACLF. And still, we don't know whether this life-threatening entity is reversible completely or not. Another point is prognostic differences among various underlying chronic liver disease etiologies. So if we study population European study population. So there were alcohol consumption followed by hepatitis C as the major underlying etiology of chronic liver disease. In North American population, alcohol was the predominant underlying cause of chronic liver disease. But in Chinese population, hepatitis B was the predominant underlying etiology. Apasal is supporting westernization of Asia regarding underlying etiology. They are of the opinion that although hepatitis B is more prevalent in China and other Asian countries, but there is significant amount of population who are actively consuming alcohol. This controversy arises because the prognostic outcome of patients of acute and chronic liver failure may differ because of a different underlying etiology for chronic liver disease. Another point is absence of one uniform global severity assessment score. So EASL has proposed its own scoring system and grading system of acute and chronic liver failure. APASL have proposed AARC scoring system, whereas Chinese group has supported Aclf system, which was already proposed by European International Society. And North American Consortium for the Study of End-Stage Liver Diseases assess their patient by assessing different organ systems. So, to sum up, acute or chronic liver failure is a life-threatening medical condition with significant global attention these days. So, various continents have contributed their part for better understanding of this clinical entity, and majority of them are agreed on overall management of acute and chronic liver failure, just like acute insult or etiology specific management, supportive management for organ dysfunction or organ failure, and even early assessment of patients for liver transplant, so that they will get liver transplant if there will be they are non-responding to the supportive treatment. But now there is a time to sit together to address these controversies in order to propose universally acceptable single definition as well as ACLF severity assessment score in light of current knowledge and literature. Thank you. So this is all about my talk, and I am open to your questions. Please feel free to ask any question if you have. Thank you.
Thank you, Dr. Fareed, for such a detailed discussion on such a controversial topic. I will take a few questions. There is a question for Dr. Farhana. It has been asked by Dr. Farhana Kayani. He says, did we compare this Nomogram with conventional biopsy for fibrosis grading?
Hello. Actually, the reason of my study was like to go for a nomogram, just to use the non-invasive markers, and I have not used the conventional liver biopsy for comparison. However, that has already, actually I have taken references of the prior studies in which that were recently published in Journal of Hepatology. Like they have already used the comparison between the non-invasive markers, and they have compared it with the liver biopsy, and they were of opinion like around, they found, and they finally concluded that around 80% in 80% of the cases it actually led us to find the fibrosis stage, and so it was the 80% correct.
Thank you, Dr. Farhana. IT team, can we take on board Ali Haider? No? Okay, so due to some network issues, they are not available. I will request Dr. Ghulam Abbas for his comments on this session.
Okay, I think 3 excellent presentations. All the 3 speakers have tried to justify why they have chosen this topic, and what we expect from them is that they would be writing some manuscript on these topics and get it published. So there are some points like Fareed mentioned about controversies in ACLF. There is also one definition of ACLF which has been given by World Gastroenterology Organization. And did you mention that? I might have missed that definition.
Sir, actually, I mentioned four societies, two from West and two from East.
Okay.
West includes EASL predominantly and NEXL, and East societies includes APASL and Chinese group which were studying. And then I compared all these four societies. And
actually, WHO, World Gastroenterology Organization, tried to become an empire and to settle the things, try to settle the things by proposing another definition, but again there was some problems with that definition as well, and this has not been accepted by either EASL or APASL. So these are my short comment about the nomogram. So Farhana, would you be creating a new nomogram, or you will be discussing different nomograms at the end of the day?
Sir, actually, I took the reference of the prior studies that
Okay.
used each non-invasive marker like APRI, FIB4, NAFLD, transient elastography, and on that basis, I created all the nomogram which was already shown in my presentation. So it took into account all the clinical examination parameters, the non-invasive markers, the history, like the history of comorbidities, and along with that, the transient elastography, including the CAP and the ultrasonography findings. So it was already, it has already been proven by prior studies. So I just took the reference of those studies and concluded this nomogram.
So how would you validate your nomogram, whether this is effective or not?
Yes, sir. Actually, that is my point. So the plan is to go to observe these patients for a further period of like 6 months, and we will follow them by another APRI, FIB4, transient elastography findings, and we'll compare that. So based on this, actually, I have done the scoring like till less than 7, because less than 7 include all those patients who have no metabolic component. They are just with fatty liver disease. So in that cases, fatty liver, so lifestyle modification along with my like diet and exercise would be enough. But if they have a metabolic component, they would come up more than 7.
There are some controversies. What should be the cutoff?
Yes, sir. Actually,
For the like FIB4 cutoff, like Indians, they have taken lower cutoffs as compared to the Europeans. Like 1.3 cutoff is suggested by the European investigators, but from India, there are some suggestions that the cutoff may be much lower, like 1.02 or 3.
yes, sir.
1.0. So there are problems with the cutoff as well, and there is some problem with age also. Like you have to stratify the patients of different ages, because as you know, FIB4 also incorporates the age of the patient also, but even the cutoffs become different with different age groups. So these are the different issues that may be there.
Definitely, sir. Definitely, the NAFLD score also incorporates age parameter. Definitely, it would be different. And I heard this like the Dr. Ajay's talk last night, and he is of opinion like, yes, we are different from the Western population, so we need to study in that. Yes, it would be a sort of limitation for me. So we'll look into that, sir.
Okay. Dr. Asim, about the overlap syndrome. So, in a nutshell, what do you want to prove in the overlap syndrome? Is this entity exist according to the, like you mentioned about the Paris classification? And if do you feel like that this is a spectrum of the same disease which may progress from one end to the other end?
Thank you, sir. Actually, overlap syndrome does exist. Whatever the variant is, it does exist in the literature, in the real world. But it's very rare. This is something we should keep in mind. and the bottom line was I wanted to prove that primarily we should treat the primary process and the predominant process first and give it a bit of time so that we can see the response. Like one of the study I went into and I mentioned in my presentation, it was like all the BBC patients who were untreated for about 4 years, they developed interface hepatitis. So I think it's the treatment of the primary and predominant process. It should be properly and appropriately treated and given time.
Okay. Thank you very much.
Thank you, sir.
Thank you very much, Dr. Ghulam Abbas, and thank you very much, all the three rising star. So with this, we will conclude this session of Rising Star. Our next session, which will start after this, is one of the interesting session, and which is basically from liver transplant to personalized patient care. And we have a well-known eminent speaker in this session. I will request Dr. Atif Majid, who will be moderating this session, to take over the mic and continue his session. Thank you very much.